everyone and welcome back. So we are going to start the pathology of the endocrine system. The first disease that we will be discussing is syndrome of inappropriate antidiuretic hormone secretion. We have studied the ADH hormone and its normal function. Now whenever there is any pathology, then what happens, we will discuss this. So the first one pathology for ADH is the syndrome of inappropriate antidiuretic hormone secretion. ADH is secreted by the hypothalamus and it goes to the posterior pituitary, and then it releases the antidiuretic hormones, and it acts on the kidneys to secrete the ADH hormones. Now it is characterized by the excessive free water retention. Whenever there is ADH syndrome of inappropriate ADH, then it is characterized by excessive free water retention, euvolumic hyponatremia, with continued urinary sodium excretion. Urine osmolality is greater than serum osmolality. What happens when ADH is secreted overly? Then it leads to the retention of water in the body in excess amount. As a result, the water is excess and the electrolytes, that is sodium, is decreased. So as a result, the urine osmolality, that is the urine viscosity, is increased than the serum osmolality, as there is excess water in the serum. So the balance of the electrolytes, sodium and the water, is disbalanced, and the urine osmolality is increased compared to the serum osmolality. Okay, now the body responds to water retention with the aldosterone. How the body balances the system? The body responds by to the water retention by decreasing the amount of aldosterone in the body, and the release of ANP, anti-natriuretic peptides, and B type natriuretic peptides. So ANP and BNP are released by the cardiac. As the excess amount of water increase in the body, then it leads to the pressure on the cardiac system, and cardiac system release ANP and BNP, which leads to the increased urinary sodium secretion to make the balance. Now the normalization of extracellular fluid volume occur through this mechanism, and euvolumic hyponatremia take place. Now, what is the treatment of this syndrome? Fluid restriction, which is the first line treatment. Then salt tablets should be taken, as there is excessive fluid and less salt, so the salt tablets should be taken. And IV hypertonic saline can be used, diuretics can be used, and ADH antagonist, for example, conivaptan, tolvaptan, and demiclocycline. These can be used to as diuretics, which leads to the excess fluid excretion, and the balance of electrolytes and the water in the body. So ADH leads to the excess retention of the water, so we will provide such treatment that can get rid of this excess excretion, excess water in the body, and there is balance between the water and the sodium in the body. Okay, also this system is activated by ANP and BNP, BNP, and decrease the ADH, and also suppress the renin angiotensin converting enzyme system. As a result, the excess water is excreted and the retention is decreased. So there is a balance between the sodium and the water. Okay. Now, what are the causes of this syndrome? So, head trauma or CNS disorder, as there is hypothalamus and ADH is secreted here. So, head trauma or CNS order. Then, ectopic ADH, whenever there is ADH secreted from any other glands, then this leads to the water retention. For example, small cell lung cancer. So, this is the cause. Exogenous hormones, for example, vasopressin, desmopressin, and oxytocin. If these hormones are exogenously coming to the body, then this leads to the SIADH. Okay, lung disease can also leads to this defect, and the drugs, for example, SSRIs, carbamazepine, and cyclophosphamide. This also lead to the excessive water retention in the body, and it can lead to the syndrome of inappropriate ADH. Okay, now coming towards primary polydipsia and diabetes insipidus. So this is also a pathology, and it is characterized by the production of large amounts of dilute urine and thirst. Urine specific gravity is less than 1.006. Urine osmolality is usually less than 300 milliosmol per kg. Central diabetes insipidus may be transient if damage is below hypothalamic median eminence or in the posterior pituitary. ADH in hypothalamus can still be secreted systemically via portal capillaries in the median eminence. Okay, so what is primary polydipsia? Uh, and what is diabetes insipidus? So in all these defects there is the large production of large amounts of dilute urine means there is no increased osmolality or viscosity. There are no sodium or electrolytes. Excessive electrolytes excreted in the urine. So the urine specific gravity is 1.006 and the urine osmolality is less than 300. The central diabetes insipidus may be transient if the damage is below hypothalamus. Okay, the ADH in hypothalamus can still be secreted systemically via portal capillaries in median eminence. Now, what is primary polydipsia? The definition is excessive water intake, and the causes may include psychiatric illness, hypothalamic lesions, and which affects the thirst center. Now, the serum osmolality is decreased in the primary polydipsia. Also, the ADH level is decreased or normal. Primary polydipsia is not usually due to the ADH effect. The water restriction is significant increase in the urine osmolality, that is 700 milliosmol per kg. The treatment is water restriction as there is no ADH involvement in the primary polydipsia, so there is no need of desmopressin. Okay, now central diabetes insipidus. In central diabetes insipidus, there is defect in the brain which leads to decreased secretion of ADH. So, idiopathic brain injury, trauma, hypoxia, tumor surgery, and infiltrate diseases are the causes of central diabetes insipidus. The serum osmolality is increased in the central diabetes insipidus. As there is no retention of the water, so the water is excreted in the urine and the serum osmolality